She went off birth control at 28. And for the next 18 months she had no period at all. And then it came back. With a vengeance. 2 weeks of debilitating pain. Every single month. Pain she rated an 8 out of 10, at sometimes a 9. And when she went to doctors, doctor after doctor after doctor, do you know what they told her? Take ibuprofen. That's just how periods are. You're probably just sensitive. She had PCOS, she had endometriosis. And she had Hashimoto's thyroiditis. 3 separate conditions. All interacting. All making each other worse. And not a single doctor had connected the dots. Today we are going to talk about what it looks like when your body is fighting 3 battles at once. And the medical system keeps telling you there is only one. We are going to talk about why up to 90% of women with PCOS never receive a diagnosis. Why painful periods are never ever normal no matter how many people have told you otherwise. And what the right treatment plan can actually do for a woman who has spent years living at an 8 out of 10. Because here is what nobody tells you. It does not have to be this way. A 3 or 4 out of 10 instead of an 8 or 9. That is not a miracle. That is medicine. Done right. If this is the kind of conversation you have been waiting for someone to have, you are in exactly the right place. Hit that subscribe button if you haven't already, because every week this is what we do. Here. We have the conversations nobody else is willing to have. Now let's get into it. Part 1, 3 diagnoses, 0 answers. Until someone finally listen. What happens when the system fails you at every turn? Imagine going through your entire childhood, your teenage years, your 20s, educated, curious, capable, and still having absolutely no idea what is happening inside your own body. That is not a failure of intelligence. That is a failure of the system. She went to private school. She graduated from one of the most prestigious universities in the world. She reads voraciously. She asks good questions. And she still did not have the language for what her body was doing until she was 30 years old, because no one gave it to her, because no doctor sat down long enough to explain it. When she went off the pill after more than a decade, her period disappeared for 18 months. And when it came back wrong. 2 weeks of pain out of every 4. Lying in bed. Unable to function. Rating her pain an 8. Sometimes a 9. On a 10-point scale. Every single month. For years. And the responses she got from the medical community. Take ibuprofen. Painful periods are normal. Maybe you're just sensitive. I want to sit with that for a moment, because she is not alone. She is describing the experience of millions of women who go to the doctor with real, measurable, life-altering pain and are sent home with a generic recommendation and a dismissal. To be why the time she found a doctor who actually listened, who sat with her for 45 minutes, not 5, who explained not just the diagnosis but the why behind every single treatment choice. She was already years into living a diminished version of her life, and within a year of the right treatment plan, she was at a 3 to 4, not an 8, not a 9. A 3 to 4. The difference was not a miracle drug. The difference was a doctor who listened. Takeaway number 1. If you have been dismissed, if you have been told your pain is normal, your symptoms are just stress, your body is just sensitive, please hear this. You are not being dramatic. Your pain is real. And you deserve a care provider who treats it that way. If the doctor in front of you is not asking the right questions, find a different doctor. You are not being difficult. You are being your own best advocate. And that is the most important thing you can do for your health. Part 2. PCOS, the condition nobody explains even after they diagnose it. Why getting the label is not the same as getting help. Here is something that I think is one of the most underappreciated failures in women's healthcare right now. That a woman goes to a doctor. She lists her symptoms. The doctor runs some tests. And then asterisk, you probably have PCOS, there's not much we can do about it. Asterisk, and she goes home. No explanation of what PCOS is. No discussion of what is causing her symptoms. No treatment plan. No roadmap. Just a label and the door. This happens constantly. And it is one of the most harmful things that can happen to a woman with this diagnosis. Because PCOS is not one thing. It is a syndrome, a constellation of symptoms that vary enormously from woman to woman, and the treatment plan has to be built around the specific person in front of you. Not a textbook. Not a protocol. So let me give you what so many doctors never do. Let me explain what PCOS actually is and what it actually does. PCOS at its core is a hormonal condition driven primarily by insulin resistance. Your body produces insulin in response to carbohydrates and sugar. In someone with insulin resistance, that process is less efficient. The body compensates by producing more insulin. An elevated insulin drives elevated androgens, testosterone-like hormones that cause the symptoms you probably already know: irregular periods, acne, hair loss, facial or body hair. Weight that is extremely difficult to shift despite eating carefully, mood instability, anxiety, sometimes depression. And here is the thing about that weight. Peace, because I think it deserves its own moment. PCOS patients are often told to eat less and exercise more. As if they haven't tried. As if they aren't already eating less than their friends and exercising more, and still gaining weight while their body is blamed for something their metabolism was never designed to do. There is a statistic that stops me every single time I say it. An estimated 70% of PCOS patients have a history of eating disorders. 70%. Not because they are fragile, not because they are vain, but because they have spent years being told that their body's inability to process carbohydrates efficiently is a willpower problem, and they have tried every desperate measure to solve it. This is why correct diagnosis is not just a medical issue. It is a mental health issue. It is a body image issue. It is a self-worth issue. And it starts at a very young age. What does treatment actually look like? It depends entirely on the individual presentation, but here is the framework. For acne and androgen symptoms, low-dose birth control or spironolactone, an anti-androgen medication that acts like a vacuum on free testosterone. For irregular periods, hormonal regulation through low-dose pill, progesterone IUD, or other progesterone-based options. For insulin resistance, metformin, which makes cells insulin sensitive and helps the body process sugar the way it was designed to. For significant weight concerns, GLP-1 medications have been transformative for PCOS patients, not just for weight management, but for the metabolic dysregulation at the root of the condition. For inflammation, anti-inflammatory nutrition, consistent exercise, and targeted supplementation can significantly reduce the systemic inflammation that drives so many PCOS symptoms. A note on birth control pills and PCOS. For some women, they are incredibly helpful. But for PCOS patients who already struggle with anxiety and mood, the hormonal shifts from the pill can sometimes make those symptoms worse. And here is something almost no one is told. Staying on a continuous birth control pill for more than 7 to 10 years can, in a small percentage of patients, chronically suppress ovarian reserve. Which means if you have been on the pill for a decade or more, it is worth asking your doctor to check your AMH, your egg count. Not to alarm you, but because knowing your number is always better than not knowing. Takeaway number 2. If you have a PCOS diagnosis and no treatment plan, that is not the end of the conversation. That is the beginning of it. To go back. Ask specifically, what are my androgen levels? What does my insulin resistance look like? What are my treatment options, all of them? And what is the plan if this doesn't work in 4 months? You deserve a plan. Not a label and a door. Part 3. Endometriosis. The disease that hides behind the one nobody takes seriously. Why PCOS and endometriosis are not the same and why so many women have both. There is a misconception I want to clear up directly. Painful periods are not a symptom of PCOS. Painful periods are a symptom of endometriosis. These are 2 different conditions, with 2 different mechanisms, and 2 different treatment paths. And yet they are frequently conflated, or one is diagnosed while the other is completely missed. PCOS is about hormones and metabolism. Endometriosis is about tissue, endometrial-like cells growing outside the uterus responding to the monthly hormonal cycle, bleeding with nowhere to go, creating inflammation, scarring, and pain. So why do so many women have both? The research is still catching up, but here is one mechanism that matters. When a woman with PCOS has irregular periods, sometimes going 6 months without one, and then finally bleeds, the flow can be heavier. And in some of these cases, blood travels retrograde, upward through the fallopian tubes and into the pelvic cavity, where it implants as endometriosis. Month after month, cycle after cycle, those implants grow. They respond to estrogen. They cause more inflammation, more scarring, more pain. And because painful periods are so routinely dismissed, just take ibuprofen. That's how periods are. Endometriosis goes undiagnosed for an average of 9 to 11 years. She was living at an 8 or 9 out of 10 every month. 4 years. Before anyone connected it to endometriosis. How is endometriosis treated? The gold standard is laparoscopic surgical resection, minimally invasive, outpatient, and done correctly, life-changing. But it requires a surgeon who knows what they are looking for. Because endometriosis lesions do not always look the way textbooks show. The classic dark brown implants are only one presentation. Many lesions are small, white, nearly invisible. and require magnification, and an experienced iato find and correctly removed. An inexperienced surgeon can look into the pelvis, see nothing obvious, and tell the patient she does not have endometriosis when she does. For patients who are not ready for surgery, or whose disease is earlier stage, progesterone-based suppression is the first line of treatment. Low-dose combination pill. Progesterone-only pill. Progesterone ID. Or medications that lower estrogen directly, because estrogen feeds endometriosis and reducing it starves those implants. But here is the non-negotiable ***: surgery without hormonal suppression afterward is not a cure. ***: endometriosis grows with estrogen. If you remove the lesions but leave the hormonal environment unchanged, the disease will return, often within 6 months to 2 years. Every woman who has endometriosis surgery needs a post-surgical suppression plan. If your doctor does not discuss this, ask. Takeaway number 3. If you have been told your painful periods are just something to push through, bring the word endometriosis to your next appointment. Ask specifically to be evaluated. Ask about your options before and instead of surgery. And if you have had surgery without a suppression plan afterward, ask what the plan is now. Because managing this disease long-term requires more than one conversation. Before we move into the third condition we're covering today, I want to take just one breath and ask you something. Is there a woman in your life who has been living in pain and being told it is normal? A friend, a sister, a daughter, a colleague, someone who has been bouncing from doctor to doctor with no real answers? If this video is giving her something she has needed, please share it right now. Because the information in this video is the kind of thing that changes the trajectory of someone's health. And it only does that if it reaches her. Hit the like button so this reaches more women who need it. And if you are not subscribed yet, do that now. Because we do this every single week. And next week's conversation is one you will not want to miss. Okay, let's keep going. Part 4. Hashimoto's, the third piece of the puzzle nobody mentioned when your immune system joins the fight against you. There is a third condition in this story that does not get as much airspace as the other two. But it matters. Because it was there. Quietly. Adding to the exhaustion. Adding to the weight gain. Adding to the fog that made everything harder than it needed to be. Hashimoto's thyroiditis. An autoimmune condition in which the immune system attacks the thyroid gland. The thyroid is a small gland in the front of your neck that regulates metabolism, energy, body temperature, mood, and weight. When Hashimoto's develops, the immune system gradually damages the thyroid tissue. In the early stages, the thyroid can swing high, producing too much hormone before it eventually crashes. When it crashes, the symptoms arrive: exhaustion, weight gain, feeling cold when no one else is, brain fog, a bone-deep sluggishness that sleep does not fix. And here is the complication that matters most for women with PCOS. Many of these symptoms are identical: fatigue, weight gain, mood disruption, metabolic sluggishness, which means without comprehensive hormonal testing, including thyroid function, not just sex hormones, a doctor can miss Hashimoto's entirely, or attribute all the symptoms to PCOS and never investigate further. This is why, with any PCOS patient, thyroid function should be part of the initial workup, not as an afterthought. As a standard, treatment for Hashimoto's typically involves thyroid hormone replacement, medication that supplements what the damaged thyroid can no longer produce adequately. But medication alone does not always tell the full story. For many Hashimoto's patients, dietary intervention, reducing gluten and dairy, which can trigger immune reactivity, can meaningfully reduce the inflammatory burden, though it is not a one-size-fits-all solution. And it requires a care provider willing to look at the whole picture, not just the lab values. There is also something worth naming about the connection between PCOS, endometriosis, and Hashimoto's at a systemic level. All three involve some degree of inflammation. All three have autoimmune components. All three are worsened by chronic inflammatory load, from diet, from stress, from an immune system that has been running too hot for too long. This is not coincidence. This is the body speaking a consistent language, saying that something in the inflammatory environment needs to change. Takeaway number 4. If you have PCOS, make sure your thyroid has been comprehensively evaluated. Not just TSH, full thyroid panel, T3, T4, and thyroid antibodies. Hashimoto's can exist even when TSH is in the normal range. And if it is there, it is worth treating because it is contributing to every other symptom you are already managing. Part 5. What it feels like to finally be heard. And why that changes everything. The secure love connection. There is a moment in this story that I want to hold for just a little longer, because I think it is the most important moment in the whole conversation. She described going to see her doctor, crying before she even sat down, just walking into the office and beginning to cry, because she was so tired of hurting, so tired of being dismissed, so tired of living at an 8 or a 9 and being told that was normal. And her doctor did not rush her, did not hand her a prescription and send her out the door. She stayed. She listened. She explained. She built a plan together, not for her, together with her. And she came back 4 months later. And again after that. And over time from 8, from 9, down to 3, down to 4. And she described it as feeling like a completely new version of herself. I want to talk about what that actually is, because I think we underestimate it. When a woman's pain is finally taken seriously, when someone with authority looks her in the eye and says, "This is not acceptable. This is not what you have to live with, and here's what we are going to do about it," something shifts. Not just physically, emotionally, in the relationship between herself and her own body. For years, she had been in conflict with her own physical experience. Her body was telling her something was wrong. The world around her was saying she was overreacting. And when you live in that tension long enough, you stop trusting yourself. You start minimizing. You start apologizing for the amount of space your pain takes up. And that erosion of self-trust, that quiet disconnection from your own inner signal, is one of the most damaging things that chronic dismissal does to a woman. Because here is what secure attachment to yourself looks like. It looks like trusting your own experience. It looks like bringing your symptoms to a doctor without preemptively minimizing them to make the appointment easier. It looks like saying clearly without apology, "I am living at an 8 out of 10, and I need that to change." That is not demanding. That is not dramatic. That is a woman who has learned to take her own experience as seriously as she takes everyone else's. And the moment she found a doctor who matched that seriousness, everything changed. Takeaway number 5. The relationship between you and your healthcare provider is one of the most important relationships in your life. It should feel like a partnership. You should feel heard. You should leave with a plan, not just a prescription. And if you do not feel those things, you are allowed to find someone who makes you feel them. Not because you are difficult, because you deserve actual care. So let's come back to where we started. A woman, living at an 8 out of 10, every month, for years, bouncing from doctor to doctor, crying before she even sat down. She had 3 separate conditions working against her simultaneously: PCOS, endometriosis, Hashimoto's, and not one of them had ever been fully explained to her, let alone all 3 together. And then one doctor, 45 minutes, a real conversation, a real plan, and a year later a 3, a 4, a life she could actually live. Here is what I want you to carry from everything we talked about today. 1. Up to 90% of women with PCOS never receive a diagnosis. If you have irregular periods, acne, unexplained weight struggles, anxiety, or a family history of insulin resistance, bring the word PCOS to your next appointment. By name. Today. 2. Painful periods are not normal. They are never normal. They are a symptom, and the most common symptom of endometriosis. If you have been told to push through, find a doctor who will investigate instead. 3. If you have PCOS, ask for a full thyroid panel, not just TS8, the full picture, because Hashimoto's can hide in the normal range, and it may be contributing to every symptom you are already trying to manage. 4. Getting a diagnosis is not the same as getting help. You deserve a treatment plan specific to you, explained to you, built with you. If you left your last appointment without that, go back. Ask for it. 5. You are not dramatic. You are not overreacting. You are not too sensitive. You are a woman whose body has been speaking clearly, and who deserves to finally be heard. And here is the thread that connects all of this to everything we talk about on this channel. Secure love, the kind that sustains us, the kind that heals us, begins with the relationship we have with ourselves, with trusting our own experience, with refusing to minimize what our body is telling us, with finding people, doctors, partners, friends who treat our inner signal with the same respect we have learned to give it. If this video gave you language for something you have been living, drop a comment below. Tell me, which of these 3 conditions did you not know could coexist? And if you know a woman who has been dismissed, who has been told her pain is normal, who has been bouncing from doctor to doctor with no real answers, please share this video with her. Because 90% of women with PCOS never get diagnosed. And you might be the reason one of them finally does. If you are not subscribed yet, this is your moment. Hit subscribe, turn on the bell, and I will see you right here next week. Thank you so much for being here. I'll see you then. Blue Heart.